Welcome to the conference session titled Living with Graft versus Host Disease. Thank you for joining us. My name is Nkirika Ashadu, Program Content Manager, and I'll be moderating the presentation for today. As we get started, we want to recognize the generosity of our corporate sponsors and our patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. If you are participating online, please feel free to submit questions at any time during the presentation from the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing your question, hit enter. We'll do our best to get to all questions. When asking questions, I respectfully ask that you do two things to help me manage the incoming questions. One, submit your entire question at the same time, and two, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your health care. Today's specialist is Sagar Patel. Dr. Patel's clinical and research expertise is in blood and bone marrow transplantation. He has a particular interest in allogenic hematopoietic cell transplantations, as well as cellular therapies such as CAR-Ts for the treatment of malignant and benign hematologic diseases in adult patients. Dr. Patel's research interests focus on the management of potential complications of such therapy, including disease relapse and graft versus host disease. His work includes research and committee collaboration through such national and international organizations such as ASTCT, CIBMTR, ASH, and EBMT. He completed his medical school and internal medicine training at the University of Minnesota. Dr. Patel then completed his hematology and medical oncology fellowship at the Cleveland Clinic, with a subsequent fellowship there specializing in BMT prior to joining Huntsman Cancer Institute. Dr. Patel is also the Director of Communications and Media Relationships for the Division of Hematology. With that said, welcome Dr. Patel.
Thank you for the introduction, and I'm excited to be here today and share a little bit about graft versus host disease as it pertains to patients who have undergone a transplant for aplastic anemia or MDS. So this is a brief overview of some of the areas I'd like to cover today, and that'll include a little bit of a primer again on bone marrow transplant, common complications, late effects, graft versus host disease, and then long-term survivorship after a bone marrow transplant. So for many blood diseases, we actually perform really two types of bone marrow transplants, and it's important to sort of keep these really sort of separated because they are very different. And the first one we have heard of is something called an autologous transplant, and that's really where you get your own stem cells back after receiving strong conditioning chemotherapy. And then an allogeneic transplant, which is really the focus of today's talk, is where you receive stem cells from a donor, a different person, and that again is after strong conditioning chemotherapy. And allogeneic transplants in general are potentially curative in patients with aplastic anemia and or MDS. And when we receive stem cells from a donor, this naturally can result in an immune reaction. And that immune reaction of interest today for us is something called graft versus host disease. And in addition, the chemotherapy or radiation that goes along with the transplant can certainly cause other complications, including infection or organ injury. And so just to kind of map out what an allogeneic stem cell transplant really looks like, there's a couple of key steps to this. And first is, collecting the donor cells. Then we process them. And then the recipient, the patient, in this diagram here, is actually receiving this conditioning chemotherapy that prepares them to receive these new incoming cells. In addition, it creates essentially space in the marrow for the new stem cells to grow and to help prevent rejection. Along with that, they start a series of medications to help prevent graft versus host disease, and that's what we call GVHD prophylaxis. And then finally, the stem cell infusion occurs, and this is where the stem cells are essentially like a transfusion and administered via a catheter to the recipient. And that's all typically done generally inpatient in the hospital. And so the reason why that primer is important is when we think about what are the factors that influence development of this complication called graft versus host disease. It's really a balance, and it's a balance. In one aspect of it is having an optimal donor, and the better match you are, essentially, the less risk of graft versus host disease, better survival, better engraftment, and then the inverse also being true. That being said, whenever we have graft versus host disease, it's traditionally felt to be sort of in parallel with the graft versus tumor effect, which is actually beneficial. What we do want to actually take care of the MDS or the leukemia. That is less important in aplastic anemia because that is generally thought to be more of an autoimmune process where we don't necessarily need this graft versus tumor effect, and we actually try to figure out ways to minimize that as much as possible. And as Dr. Pulsifer mentioned in the previous talk, we often use a bone marrow graft source so that we actually collect the stem cells from the donor from a bone marrow harvest rather than from peripheral blood collection. And the reason why is when we do that, we actually end up getting less T cells that are generally implicated in driving this graft versus host disease. And so before we get into that in a little more detail, I think it's important to sort of think about, what are some of the early complications that we see after a bone marrow transplant? And, kind of sort of creating the timeline here of the first several months, things that we're looking out for and monitoring very closely include things like graft failure, toxicity actually related to just the chemotherapy and or radiation. And so this, not surprisingly, can cause things like mouth sores, nausea, vomiting, diarrhea, fatigue, thinning or loss of hair. In addition, and not surprisingly, this can cause hematologic issues too. Low platelets, low hemoglobin, low white count. And given the intensity of this type of treatment, it does sort of strip away all the immunity to all the prior infections or vaccines you may have ever had before. And so that can increase the risk for infections. And that's part of the reason why we later start a pre-planned vaccination schedule, which essentially mirrors that for what we do in newborns, in infants. And so that's an area that we also try to use medications to help prevent infections. So these are antiviral, antifungal, antibacterial medications. In addition, organ toxicity, and these are generally less likely to occur in more fit patients and those who don't have pre-existing medical problems. And this includes certainly cardiac issues, pulmonary, renal, hepatic. Those are probably the top 4 organs that we pay attention to even when we are first figuring out who's going to be a good candidate for a transplant, as those 4 typically have the best prognostic value for deciding how you may have or may not have complications. In addition, and certainly rare but possible, you could certainly have central nervous system effects. So this could look like seizures. And then rarely bladder, there's certain chemotherapy drugs that can cause inflammation there. Now these complications differ from those that occur even closer to a year out. And we term these sort of generally as late complications. And this includes chronic GVHD as opposed to acute GVHD. Again, infections can still be a problem even at this time point. But then we do start to think also about, given the intensity of the treatment, is it possible that we could have inadvertently caused a secondary malignancy? And this could look like an MDS or an AML, maybe a lymphoma, or even a solid tumor disease. In addition, any of these late complications can have impacts on quality of life as well as psychosocial issues. And then, as we listed on the prior slide, we can still have issues with organ toxicity. Often these are things that can be rather insidious, things like coronary artery disease, pulmonary fibrosis, chronic kidney disease. In the liver, you can get something called iron overload, where it's essentially from getting lots of transfusions over time, which is particularly relevant to our aplastic anemia and MDS patients, that iron unfortunately starts to accumulate in the body as the body doesn't really have a great mechanism to remove that extra iron. And so when we think about the risk factors for these late effects, it's actually a variety of different elements at various different time points that really influences this. And certainly from the sort of beginning, not the comorbidities is kind of the medical term for it, but basically the pre-existing medical problems that are unrelated to the aplastic anemia or the PNH or the MDS, such as heart issues or kidney issues, that certainly can play a role. Smoking history, these are sort of known risk factors for developing later complications. In addition, the actual therapy itself that we administer for treating the MDS can play a role later down the road. The intensity of the conditioning regimen, as there are toxicities, as I mentioned, from the actual chemotherapy and or radiation. And if people do develop graft versus host disease, that also can lead to, even if it's successfully treated, can lead to late effects down the road. In addition, infections and then side effects from some of the medications we actually use to do a transplant can also cause issues later on. And then there are also factors that are harder to control or modify, and these are things like genetic issues. But then there are modifiable factors, such as lifestyle choices. So nutrition and exercise are important parts of this equation too. And so when we see patients and figure out and try to predict, who is going to be at higher risk for these late effects, these are some of the areas listed here that we focus on. And this includes certainly past and current medical problems, especially the non-hematologic disease that we're focusing on. Family history, so we also try to make sure that, and this becomes important when we're trying to figure out who's going to be a good donor. If we're especially using a relative, we want to make sure that there isn't a hereditary sort of cancer predisposition syndrome, for example. And then also looking at, family history for other comorbidities such as heart disease, diabetes in particular. And then for some patients, they may have, depending on their type of employment, occupational exposures. So this could include certain chemicals, irritants, and many others. And then, as I mentioned, certainly lifestyle factors are also really important here to mitigate late effects, and certainly activity, exercise, sleep, coping, and family support are really, really important here. And then finally, certain habits such as use of smoking, alcohol, illicit drug use, those things can also impact outcomes after a transplant as well. And so to focus a little bit more on this complication is called graft versus host disease. And it really is essentially just tissue damage from the transplant that unfortunately leads to a cascade of reactions that occur in various different organs. And this tissue damage basically activates these part of the immune system, these antigen-presenting cells, and then that leads to these T cells activating. And you can kind of see that in the green here. And then subsequently, those activated T cells then lead to, unfortunately, cellular and inflammatory sort of effectors. And these effectors essentially then cause damage to either the skin or the gut. And that's the actual clinical presentation that then starts to become evident. And so when we think of graft versus host disease, there are really kind of two major sort of entities within that. And the first is acute GVHD, and this typically occurs earlier post-transplant. And really the three key organs that we focus on are skin, the gut, and the liver. And then that contrasts with chronic GVHD, which certainly can occur a little later, and in a slightly different time period, but it also has a different manifestation. And while it can affect the skin and the gut, it also can affect the mucosa, the eyes, joints, and it has more of an autoimmune sort of presentation to it. And as I mentioned, certainly in terms of risk factors, the greater the mismatch between the donor and the recipient, and as well as the use of peripheral blood versus bone marrow, stem cell source can be some of the well-known and well-established sort of risk factors for developing graft versus host disease. And when patients do develop this complication, it certainly does require the use of immunosuppression, which inadvertently and as a byproduct of the disease itself can lead to also a greater risk of infections and unfortunately higher rates of morbidity and mortality. While classically we've always thought of graft versus host disease as just this sort of acute and chronic and sort of day 100 being this artificial line in the sand, in reality it's a little bit more complex than that. And as this sort of figure demonstrates, there are patients who have features of both and can have kind of an overlap syndrome, as well as patients who are even beyond the 100-day mark that develop this acute presentation. And it really depends on putting together the symptoms in the right context to figure out which sort of category applies best. And so this is a newer change in perspective, and it affects ultimately how we treat the disease as well. And so I like to kind of demonstrate here a little bit the timeline and time course of at least acute, sort of late acute, and then classic chronic graft versus host disease. And as you can kind of see here, basically as time goes on, we have impacts from alloreactivity and immunodeficiency. And ultimately what that leads to, and you can kind of see that in the blue here, the first peak, is sort of when typically we may see the acute graft versus host disease start to develop. And then the risk of that starts to subside as time goes on, and then unfortunately that's traded off for the increasing risk in chronic GVHD. Ultimately what's happening down at the cellular level is we have something called inflammation, and then injury from either the chemotherapy and the intensity of the transplant, hopefully some degree of repair. But if there isn't complete repair, even years out, we can get fibrosis, which is sort of an end-stage manifestation of the graft versus host disease. And so what does this look like? Well, as I mentioned, this can affect a variety of different organs and different sites and to various different intensities as well. And so no two patients with graft versus host disease will have the same experience or be on the same treatments necessarily, because it can have such a heterogeneous presentation. And certainly can affect skin, joints, eyes, mouth, amongst many other sort of sites, including the lungs as well. And so each of these requires very specialized treatment and being ideally seen with a graft versus host disease expert. And so focusing a little bit more on the acute graft versus host disease. So really here we're thinking more about that this is an immune reaction that's mediated by the donor's T cells. And as Dr. Pulsifer has kind of highlighted as well, occurs typically in around 30% of patients. Hopefully, with the development of newer ways to prevent graft versus host disease, we can see that number come down. But as of right now, about 4,200 patients in the United States develop this each year. And again, typically occurs within the first 100 days of transplant. And those areas, those organs that are involved ultimately lead to developing diarrhea that's pretty profound, that could lead to the need for hospitalization, skin rash that can be on large parts of the body, and typically not symptomatic, but something we detect on a blood test is inflammation around the liver capsule. And you can kind of see some representative images here affecting the skin. Now, when we figure out how to stage and grade graft versus host disease, there are some established criteria, and they really focus on those three organs, and then ultimately on how severe each and every one of those organs are. And that can correlate ultimately with how aggressive the disease is, and then consequently, we match our treatments based on that as well. And so patients can have one or two or all three different organs involved to varying degrees. And ultimately, we put that all together to figure out and best categorize and track, especially when it comes time to figure out if patients are responding to treatment. Now, what are the major treatments for this? Well, the first and what has been the standard for many, many decades is actually high doses of steroids. So these are typically can be given initially maybe as IV, but for many patients ends up being an oral medication. And things that you may have heard of are medications like prednisone. And that can be effective in about 2/3 of patients. Unfortunately, the remainder need to move on to second or third line treatments. And this includes agents such as ruxolitinib, which is an FDA-approved medication, in addition to other sort of ways to cool down the excess immune response. And one of the other techniques that we use to help with this is something called ECP, extracorporeal photopheresis. So basically it's a procedure where we actually do it here on site, where we actually zap the blood using a special machine. And that helps reduce some of those overactive T cells. And then there are a lot of other sort of off-label use of immunosuppressants that we can try to get the acute graft versus host disease to essentially cool down this extra immune response and help minimize damage to sort of the innocent bystanders, right? And in addition, we try to combine some of the systemic therapies with local treatments as well, because this can also improve symptoms and work in conjunction. And so, for example, like a skin rash, we would also consider applying topical steroid ointments. And for some patients who have, say, gut involvement, like their upper GI system, we can actually provide oral steroids that can be drinkable, that can also help treat the sort of lining of the GI tract as well. Now, to contrast that, chronic GVHD looks and operates differently. And the key element here is that there is now a fibrotic process happening underlying this. And that's in addition to sort of the immune reaction. In addition, we believe that there's not only just the T cells that are active, but also B cells as well. And again, this is occurring in about 1/3 of patients. And at least in the United States, there are significantly larger numbers of patients with chronic GVHD, and this can be somewhere around 14,000. And this usually occurs after the first 100 days, but it can occur even years later. And patients do not necessarily have to have had acute GVHD before, though that does increase your risk of developing chronic GVHD if you've had acute previously. And the symptoms here are a little bit different. The skin rash can happen, but there also can be tightening of the skin. And the tightening could be significant enough that it affects the full range of motion of your extremities or your hands. In addition, patients can have dry mouth, dry eyes, changes in the nails, joint stiffness, changes in lung function, so they become short of breath. And compared to acute GVHD, in chronic, there are a lot more sites that can be involved. And as you can kind of see in this pictorial, they're from really head to toe, a lot of different areas that can be involved. And so this does require paying very close attention to symptoms that may develop and keeping a good relationship and follow-up with your transplant team to make sure that if these do develop, we can intervene early. Typically, I would say the skin, mouth, and eyes are going to be some of the most common ones, especially at diagnosis. And less common would be things like the lungs, the esophagus, or joints. But there are a lot of differences, again, from patient to patient. And so in terms of treatments here, again, the first line treatment is high doses of steroids. So this is, again, agents like prednisone. And then second line treatments include ruxolitinib, extracorporeal photopheresis, this ECP procedure, and then other immunosuppressants. And then now there is available a third line agent that's also FDA approved for chronic GVHD, and this is a medication called belumosudil. In addition, we like to combine systemic treatments with local therapies depending on the individual sites and organs that are involved. And this includes, for example, using topical steroid ointments for a skin rash, for those patients who have dry eyes, using prescription strength sort of lubricating eye drops, special oral rinses if they have mouth involvement. For those patients who have lungs that are involved by this, we can use inhalers to help release some of those symptoms. And the grading and staging of chronic GVHD is a little bit more complex because there are so many different sites that can be involved, and each and every one of them has particular sort of areas that we focus on. So you can kind of see in this pictorial, for example, that in some patients who have joint involvement, for example, we actually have them do a variety of sort of exercises in the clinic, very simple maneuvers to actually measure how much they can move various joints. So, for example, the shoulder, elbow, wrist, and ankle, and we can actually measure that and get a sense of how severe the chronic GVHD is. And ultimately, we can also measure and combine this together with a scoring system to figure out how impactful this is to the patient. Ultimately, we take all that data and figure out what's going to be the best in terms of treatment. And really, there are going to be three major sort of pillars that we focus on when thinking about GVHD. And the first is trying to get a good diagnosis, because sometimes it can be unclear and it could be a skin rash from maybe a medication or an infection. And so often we like to get a biopsy as often as if it's easy and safe to do. And then many researchers are working on trying to identify non-invasive biomarkers or blood tests that could help us figure out that somebody is developing this. And then ruling out other possibilities, and then managing other comorbidities that an individual may have. When we do commit to doing graft versus host disease treatment, we really want to use the lowest effective steroid dose possible. And typically, when patients are living with GVHD, it does require a lot of trial and error of figuring out, let's try to taper off the steroids. We'll go down by a certain amount at a given time point, and we have to sort of test the waters to see, and hopefully you don't see that the disease can start to re-flare as we drop the medication dose. And part of the reason for that is unfortunately steroids, while they can be effective and are the first-line treatments, they do come with a lot of side effects, and that can lead to damaging effects to the bone, infection risk, amongst many others. And so we're also always trying to figure out if patients can enroll on a clinical trial, and we often have many of those available depending on sort of the timeline, to see if patients can get a treatment that's better than steroids. In addition, while we're doing a lot of the medical prescriptions or treatments, we also really want to focus on the supportive care element, and that includes preventing infection, nutrition, physical therapy, and sort of healing the gut, especially in those patients who have GI involvement. And unfortunately, 35–50% of patients will not respond to first-line steroid therapy. And so we use special definitions to figure out if patients are steroid refractory, steroid dependent, or steroid intolerant. Ultimately, there is a lot of debate still on what is going to be the best second and third line treatments. And many patients will actually cycle through a list of different treatments depending on their response and the number of sites and intensity of their graft versus host disease. If the graft versus host disease does not respond and remains persistent, it is associated with high morbidity and mortality. And so ultimately, the time course of this can vary from person to person. And as we've sort of previously seen, especially for those patients who have chronic GVHD, this is something that they can live with for many years, unfortunately, if it doesn't fully go away. That does contrast with those patients who have acute GVHD, which is generally higher risk, more intense, but typically shorter in duration. And so each of these have important impacts on quality of life, but as well as on the duration of treatment that we may prescribe. Unfortunately, as I mentioned, the GVHD treatment itself can cause problems that can also impact quality of life, and this could include immune deficiency. It could also cause cataracts in the eyes, kidney disease, dyslipidemia, and steroid-induced diabetes. Myopathy is basically muscle wasting and weakness from steroids. It could affect endocrine sites such as the adrenal glands and cause insufficiency there. It can cause weakening of the bones, and then numbness and tingling in the fingers or toes, and then issues with wound healing, and then unfortunately, and rarely, but second malignancies as well. And so when we think about graft versus host disease and its impact on quality of life, there's certainly a short-term and a long-term sort of perspective to this. In short-term, typically these symptoms, may have some gradual improvement over months, but they may overlap with other expected normal transplant symptoms. And so it can be difficult to sort of separate the two if both processes are going on, especially for those who are kind of earlier after their transplant. Especially for those patients who have acute GVHD, that often does require inpatient level of care, especially if they're having profuse diarrhea. And that does correlate typically then with having frequent medical appointments. That contrasts with those patients who are having to deal with GVHD on a longer sort of timetable, and these symptoms may be something that may be in the background for many, many years. And typically, if they're well controlled and at least stable, then they don't necessarily need to have as many or as frequent medical appointments. But they still may have side effects from the therapies that we've prescribed to help treat the GVHD. Often, something that isn't as discussed with graft versus host disease, especially in those patients who have this long sort of exposure time where they have to deal with the chronic GVHD in particular, there is a significant toll not only on quality of life, but also the financial sort of toxicity that comes with it as well. And some studies have estimated that the annual sort of cost, not necessarily to the patient, but sort of to the healthcare system, would be around $275,000. But from the patient's perspective, a lot of individuals unfortunately cannot return to work because their symptoms are so debilitating, and so that could be in around a third of patients. And then 3/4 of patients can lose many years of savings just because of medications, medical appointments, inability to work. And so these can extend, especially in those who have to be on immunosuppression for long periods of time, or have infectious complications or any other downstream complications from either the treatment or the disease itself. One way that we try to better understand the disease from the perspective of patients who have it is actually using a validated and studied tool to do so. And this is something that we call the patient-reported outcome tool. And it's a simple survey, basically, that focuses on some of the key areas that can be involved in chronic GVHD, for example. And so this includes the skin, eyes, mouth, lung, nutrition, vitality, and psychological functioning. And basically, it's an assessment of how much or how little each of those areas are involved in that particular individual. Ultimately, even though many of these symptoms may persist for a while, there also can be non-graft versus host disease late effects that can overlap in patients who have had a transplant. And this can occur even months or years in duration. And these can include things that are sometimes hard to pin down, things like fatigue, neuropathy, pain syndromes, certainly infertility, menopause, early menopause. Patients sometimes describe something like a fogginess, a chemo brain effect. And then, as I've mentioned, cataracts that can occur in the eyes, and then certainly sexual dysfunction, anxiety, depression. Ultimately, as we are doing more and more transplants than ever before, there are certainly going to be more and more survivors after transplant. And by the year 2030, we expect that we may have 500,000 in the United States of transplant survivors. And most of these are generally auto-transplant patients, in the minority fraction, 40%, being allogeneic stem cell transplant patients. Many of these are actually individuals between the ages of 18 to 59. But this underscores the importance of having a good survivorship plan because of all these late effects and symptoms that can develop later in life. And as we get better and better with our transplant strategies, with new research and better understanding of the disease and managing complications, we expect that long-term survival is going to be increasingly possible. But this may still come with late effect. And certainly, as some of these studies here show, about 66% of BMT survivors report at least one chronic health condition compared to their healthy sibling. And often, majority of these patients will have some non-malignant late effect even 5 years after a transplant. Unfortunately, life expectancy still does not match that of the general population in looking across a variety of different diseases. These differences are different in aplastic anemia, for example, as Dr. Pulsifer has kind of highlighted. But in our patients who receive a transplant for leukemia, the general population life expectancy does have some significant differences there. And so I encourage patients, that are undergoing a transplant to actually use a variety of different tools and resources to better understand and capture some of these symptoms, but then have a good understanding of what that survivorship plan may look like. And a couple of resources I wanted to highlight here that are all free and easy to use. So one is from the bethematch.org, and there's a website here where you can download essentially an application that can actually help you set reminders for medications, check GVHD symptoms, and then make sure that you're sort of following along at various time points with things that should ideally be occurring with your care team. In addition, they have a survivorship program. So if there are barriers or issues that aren't being resolved and you need additional resources or help, there's a toll-free number and email listed here where you can actually even have telehealth appointments with medical staff through Be the Match. And then another organization is called GVHD Now, and they have a downloadable link of chronic GVHD symptoms to be on the lookout for, which I think is really nice because it makes it very easy to understand areas that may be occurring that you want to be able to bring attention to for your care team to follow up on. And with that, I'll be happy to take any questions. Thank you.
Thank you, Dr. Patel. Now we'll take some questions from online. So the first question we have is, do all transplant patients develop some form of GVHD?
Yeah, great question. Luckily, the majority of transplant patients do not develop GVHD. And as I mentioned, certainly we expect that number to be closer to around 30%. Even within those patients who develop graft versus host disease, there can be significant differences in the severity and intensity of it. And for some patients, it can be very mild, such as a simple skin rash that can be treated even just with a topical ointment. And then that runs the spectrum to those patients who have more involved disease that requires systemic treatment, such as an immunosuppressant or a systemic steroid.
Thank you. Our next question is, when do patients no longer need to be concerned about developing GVHD?
Yeah, that's a great question. Certainly, the risk of graft versus host disease does decrease the further out you get. And I would say that some of the major time points that we think about are probably the 100-day mark, and certainly it's less likely to develop acute GVHD after that. And then after the 1-year time point, that would be less likely to develop chronic GVHD. That being said, the very next day after those time points, your risk does not go down to zero. It's slowly decreasing, And it also very much depends on the type of disease, the type of transplant, the type of donor, the medications used to prevent graft versus host disease, so that there are a lot of differences from person to person. But generally speaking, if a patient never had graft versus host disease in the first 2 years, it would be very unlikely to develop sort of out of the blue at 5 years out.
Thank you. And our next question is, a person said, my first transplant was not a success, and I will have a second transplant in a few weeks. Am I at greater risk for GVHD with the second transplant?
That's a great question. Certainly, we do think about the GVHD still being a possibility with even a first or a second transplant. And some of the factors that will influence that will be certainly, again, the medications that are used to prevent the graft versus host disease, the type of donor, the conditioning regimen, and how intense it is. Typically for a second transplant, we use less intense chemo than we may have used for the first transplant, just because receiving that much chemo in a relatively short period of time, even if the disease came back, can lead to cumulative sort of injury and harm to other innocent sort of organs. So we have to be mindful of that. Certainly, the care team will be highly involved in monitoring for graft versus host disease, and using the same approach previously to help prevent it is really the first step. And then if it does develop, intervening aggressively and early to help minimize effects from it.
Thank you. Our next question is, my skin GVHD never seems to be resolved. It's not a severe case, but annoying. Is skin GVHD always chronic?
Yeah, that's a great question, and it certainly depends on where along in the spectrum you are from your transplant. And so, assuming that you are, typically maybe a year out or even longer from the transplant, I would suspect it's probably more of a chronic GVHD, especially if it's been lingering around. That being said, if the symptoms are still bothersome or really have not improved, it may be still worth talking with the team to figure out if there needs to be a change in treatment and what the pros and cons may be of doing so. And especially if there is a clinical trial option that may be available, testing a new medication, that could also be very, very valuable to seeing if that can help control the skin GVHD better.
Thank you. Our next question says, lung GVHD scares me. What tests are done to check for VOS?
Mm-hmm. Yeah, absolutely. While lung GVHD is certainly a much more rare presentation of graft versus host disease, it definitely can be associated with a higher risk of dying potentially from it. And one of the ways that we help sort of mitigate that risk is we actually do a series of tests called the pulmonary function test. So it's basically breathing into a specialized machine that can measure how strong and effective your lungs are. So we actually do that even before transplant to get a good baseline number. And then we'll do it at various time points after the transplant to see if there are any subtle changes that are starting to develop. Because often the lungs can be slowly involved without people becoming symptomatic. You may not be short of breath or notice anything different because it can be very insidious. And so that's part of the reason why we preemptively do these pulmonary function tests at various time points. Ultimately, the treatment is very similar to GVHD involving any other site. It typically involves the high doses of steroids first, in addition to combining some inhaler and kind of asthma-like medications that we may use along with that. Some patients may have progressive lung GVHD that even requires oxygen, being on chronic oxygen. And so that is an area that we want to develop new treatments for and hopefully try to avoid altogether if possible.
Thank you. And another question is, prior to my transplant, I was given a lot of transfusions. I developed a mild case of GVHD. Could the transfusions have contributed to my GVHD?
Yeah, that's a good question. As far as we know, receiving blood transfusions while they have other risks, such as creating iron overload, where you get too much iron in the body and that we have to sometimes use special medications to get rid of that extra iron, we do not believe that it causes graft versus host disease or makes it worse. And so they're sort of two separate processes. And luckily, if you need transfusions, to avoid a bleeding complication, that is still going to be the recommendation and shouldn't have any impact on the graft versus host disease.
Thank you. And our last question asks, what recent advances have been made to prevent GVHD?
Yeah, so certainly one of the biggest changes that we've developed, and there are several, is the first is using this medication, two extra doses essentially of chemotherapy after you get the stem cells, and that's what we call post-transplant cyclophosphamide. So it's a very simple addition to your transplant regimen, and we're actually doing that now in other donor settings. So we used to only do that when people had a half-matched transplant, so maybe they got stem cells from a parent or a child. But in settings now where people even have a matched sibling or an unrelated donor, we're using this cyclophosphamide that can dramatically lower your risk of both acute and chronic graft versus host disease. In addition, for example, here we also have a clinical trial that's working with a pharmaceutical company to basically develop a way to remove some of the extra T cells that may be in the transplant, and that can also reduce the risk of graft versus host disease. In general, prevention is certainly the best strategy for managing GVHD, partly because it is difficult to treat when it does develop, especially if it's a more severe form.
Thank you so much, Dr. Patel, for sharing your time and expertise with us. If you would like to watch this session again at a later time, it'll be available on the conference platform in the next hour by accessing the session and clicking on the replay button, or by navigating the on-demand tab in the platform hub. If we were not able to answer your question today, you can send it to us at any time in 3 ways. The first is to send it in an email to help@aamds.org. Second is to call the AAMDSIF helpline at 800-747-2820. And last is to submit a question on our Facebook page. If you are watching online, please take a few minutes to complete the session survey. Your input is important to us and helps us plan future educational programming. Also, be sure to visit the exhibit hall and chat with the conference sponsors. The next educational sessions will start in approximately 15 minutes. This concludes the educational session of the conference. We hope you will join us for the support groups. If you are watching online, use the Zoom link in the attendee hub to join. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and for making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to help you and your family as we have for the past 40 years. This concludes the session.